do. So,
Just ma'am, 8 minutes. I'll just invite you.
okay.
Good afternoon and a very warm welcome to NITRD Central TB Division and National Task Force Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome DDG Madam from CTD, Dr. Urvashi Singh, directors and teams from NIRT, NTI, and STOs, Director of STDCs, Faculty of Medical Colleges, and District TB officers, medical officers, and others. A very warm welcome. Introducing the faculty from NITRD, I am Dr. Neeta Singla, Nodal Officer DRTB Center at NITRD. On my right is Dr. Rupak Singla. He is consultant in Department of TB and Respiratory Diseases. On my left is Dr. Saroj Meena. She is a senior pulmonologist at NITRD. I would like to welcome our director, Dr. Upasna Agrawal. Dr. Upasna, apart from being our director, she is a very accomplished senior faculty. She heads the Department of Internal Medicine for more than 20 years. Dr. Upasna runs a very successful HIV TB eco clinic also. It's called eNishchit. I request her to give her introductory remarks.
Thank you very much, ma'am, and a warm welcome to everybody who took out time and logged in today. A very warm welcome to DDGTB ma'am, Professor Urvashi Singh. And I'm happy to see that today you have a case from Srinagar being presented by Dr. Fahim Wani. And you have state experts, then you have national experts, and of course the expert team from NITRD, which is sitting on the dais and must have logged in otherwise also. So with these few words, hoping for a very fruitful discussion today, I'll just log out now. Like I won't log out, but over to you. I will be listening and learning with you.
Thank you, Dr. Upasna. We just got a message from DDG TV ma'am that she's not able to log in as of now, but whenever she logs in, we will, take her and I'll introduce her to you and we'll ask her to say a few words. So, in our series of different states discussing their cases, today's case is from state of Jammu and Kashmir. The case presentation will be by Dr. Fahim Gulwani. He is the nodal officer and for the state nodal DRTB center in the Chest Disease Hospital, Srinagar. The state expert will be Professor Naveed Nazir Shah. He is the head of the department and chairman for the DRTB center in the Chest Hospital. He is also the State Task Force Chair for the NTP in Jammu and Kashmir. The national expert will be Dr. Rajendra Prasad Sir. Sir requires no introduction. He is so senior and we all know him. He is Vice Chair of the National Task Force and he is the Director Medical Education at ERA's Lucknow Medical College. The clinic expert, difficult to TB clinic expert will be Dr. Rupak Singla, who is a consultant in Department of TB and Respiratory Diseases. And we are, of course, joined by Dr. Ashok Bharadwaj, who is the chairperson for National Task Force. So, very warm welcome to everyone, and over to Dr. Naveed for his presentation.
A very good afternoon to everybody. This case which we are discussing today actually has already been presented once at the national level in the same eco clinic. This was a very difficult case to treat. Basically, she was an MBBS student who had to leave her studies because she developed tuberculosis. Then, post starting of treatment, she had developed hyperuricemia, neuropathy, and after that, with initial response to the treatment, then the patient had a sudden deterioration. And perhaps there was more absorption of the oral drugs in the patient. So we could not achieve the MICs of drugs in the patient. So she was put on all injectable regimen, and then the patient started responding, and yes, she's about to complete her full course of treatment, and in the end, she has turned out to be sputum culture negative. Multiple numbers. Dr. Fahim will be there. He will be sharing all the details of the patient's right from start when the patient was diagnosed as a case of sputum positive pulmonary tuberculosis, and then the course of action over the next 2.5 years. Over to Dr. Fahim. So, should we share the screen and start the presentation?
Yes, sir, please.
Are the slides moving and visible?
Sir, it is visible. Just make it full screen.
It's full screen now. Are they visible now?
नहीं यहाँ full screen नहीं हुआ sir.
We are on slideshow only. I'll just stop sharing and I will reshare it. क्या शुक्र है ये जो खोली थी ना ये वाली था इसको ये वाली मुझे खोली थी मैंने are they visible now? Are they moving now?
Yeah, perfectly fine, sir.
Okay, fine. Good afternoon, everybody. I'm President.
So, sir, we're just interrupting you. DDG ma'am has just joined us. So, before we start the presentation, we'll have few words from DDG ma'am. Ma'am, thank you for joining us. You are always such a big encouragement to us, and you take so much interest in these clinics that we do. So, a very warm welcome, and over to Madam Dr. Urvashi Singh.
Good afternoon, Dr. Neeta Singla. Good afternoon, Singla sir. Good afternoon to everyone who's here today. I can see more than 180 people who have joined. And a big thanks to NITRD, Director NITRD, Dr. Upasna, and of course, the perseverance of Dr. Neeta Singla for the difficult to treat TB clinics where we cover MDR TB, and of course in the pediatric TB we must be thankful to Dr. Sangeeta Sharma, because this is a crusade they have maintained over more than 2 years now, where a lot of our colleagues learn to troubleshoot where the cases are difficult and they are unable to find a way out. Now, here particularly, Dr. Singla sir has taken up an MDR-TB case with the team here from Kashmir. What is of interest to us is Kashmir has low burden of TB, a low burden of both TB and MDR-TB, and they're carefully dealing with their MDR-TB cases. So that is very encouraging. And for the others to actually reach that low burden of DR and also TB, what we are working very hard on, TB elimination with the new strategies that we rolled out during the campaign. The idea of the BPAL M and very carefully rolling out BPAL M across the country in a carefully monitored, supervised program, and encouraging all states to actually take up BPAL M, put all the patients on this regimen, and carefully follow them up so we can, tap the adverse effects early. The reason behind the BPAL M Moxie being added despite FQ resistance is by now very clear to everyone. It was a tough call. It was a lot of evidence, a lot of scientific evidence that supported us and that actually guided us. But now a lot of other countries are actually realizing the benefit of BPAL M over BPAL. And let me tell you, a lot of Southeast Asian countries are also now following India. So India leads with our scientific mind and our commitment to reach all our patients, to benefit all our patients with the best, so far best described regimens, shortest, more efficacious, fewer pills, and of course the dosage, etc. We have decided based on the international as well as in-country evidence. Dr. Singla sir was one major, expert who stood by me when this difficult decision was taken. So thank you, sir. And there were several other experts including Dr. Anuj Bhatnagar, Dr. Solanki, Dr. Narendran from NIRT, Dr. Nair from Kerala, a few other colleagues who all of us debated and zeroed down on this. But the outcome of the rollout and how the patients are faring across the country seems to be very encouraging. We have rolled it out in all states and slowly expanding the program to cover all patients in all states. So, with these words, thank you to the team from Kashmir, whom we'd like to complete, and the discussions can then follow. Thank you.
Thank you very much, ma'am. So over to Jammu and Kashmir for their presentation. Dr. Farid, please.
Hello, ma'am. Are the slides moving?
Yes, sir, they are moving.
Good afternoon, everybody. I'm presenting a case of a young unmarried female who's a resident of North Kashmir. She was an MBBS aspirant, wanted to be a doctor. During her studies in Bangladesh, during the routine rounds in the ward, she probably contracted this illness. Started with chief complaints of cough with sputum, low-grade fever, intermittent in nature, more during night times, with profuse sweating. There was also apparent weight loss in the form of losing of clothes, decreased appetite, and decreased energy to do daily work. Initial workup of the patient revealed she visited a healthcare professional who advised an chest X-ray, and it was showing left upper zone infiltrates in the X-ray. As we can see in the left upper lobe, there's an infiltrate. They advanced a Montrose test, which was showing an induration of 19 mm after 72 hours. Sputum examination was not done. Patient was empirically started on HRZE. She took the treatment for 4 days, and then she came back to her native place to Kashmir in December 2021. At SKIMS, a tertiary care hospital in Srinagar, sputum examination was done. AFB was positive, NAT, CVNAT was positive for MTB, but it was rifampicin sensitive. She continued ATT till the month of January 2022. In January only, she developed joint pains on the left first MTP joint. She was admitted at SKIMS, and all the routine investigations were sent. Serum uric acid was on the higher side with 11.8 mg per deciliter. USG of left MTP joint was not significant. She was put on NSAIDs. PZA was discontinued 1 week before its normal duration. So patient was continued on HRE. After a month, on 10th Feb 2022, she was again admitted in the same hospital where she complained of pain in both lower legs, and there were loss of muscle mass in both her lower legs. On examination, her higher mental functions were normal. Wasting was seen in both calf muscles. Reflexes were intact, but ankle reflexes were absent on both sides. All base investigations were more or less normal. CPK and LDH were found to be normal. Chest examination was normal. MRI of spine revealed only features of lumbar spondylosis only. NCV was done, which showed axonal motor neuropathy. Owing to this, INH was discontinued. Levofloxacin was added. The patient continued on levofloxacin, rifampicin, and ethambutol, and addition of pyridoxine 40 mg. Initially, patient showed some response. Sputum AFB turned negative, and there was also some improvement in the X-ray, as we can see the December X-ray of 2021 and the X-ray of May 2022. You can see the infiltrates on the left upper lobe has decreased considerably. She was doing fine for 1.5 months. She developed hemoptysis along with fever. Following this, she were then positive and sensitive to all drugs, quinolones and second-line injectables. She was continuing on the same regimen, levofloxacin, rifampicin, and ethambutol. After that, a repeat X-ray and HRCT was done. Culture of the patient also was positive. This is an X-ray of the patient on July 2022, showing a cavity on the left upper lobe along with surrounding infiltrates. This is a corresponding CT of the same date, showing the thick wall cavity with consolidation. Also, there is some amount of bronchitis entry in birth as well. Following this, patient was referred to our center.
we obviously again repeated her all sputum analysis. She was again found to be positive. First line LPA, second line LPA, sent to all the drugs. TB culture was also positive. She was made to go through automated tests, other immunoglobulin assays, and other investigations, and it was decided to add streptomycin and levofloxacin to the regimen she was already taking. So patient started with rifampicin, ethambutol, streptomycin, and levofloxacin. Although patient didn't develop any hemoptysis after that, but her analysis done on Feb 23 was again positive for MTB. They were also positive and sensitive to quinolones and second injectables. And we can see in the X-ray there were development of bilateral infiltrates. Left were already there. So we had a lesion in right side as well. These are NAT and microscopy reports. Testing detected, rifampicin resistant, not detected. First line, second line LPA, also rifampicin resistant nor ionization resistant were detected. This is CT of the patient in April 2023, which is showing the left upper lobe cavity, thick wall cavity with consolidation with bronchitis and nodules in the right side as well. So we had issues and challenge. Patient was deteriorating. There was no radiological response. Patient was persistently AB culture positive. She was losing weight. There was no appetite. So there was a meeting. We decided to send her serum level of 80 drugs for drug levels. So drug level of following drugs were sent from levofloxacin and PZA. We in fact sent the drug levels on two separate occasions. First, we had a doubt maybe there was some problem with the sample shipment because it was showing absolutely zero levels after 2 hours. We repeated after 2 weeks. Again, it was showing zero drug levels at 0, 1 hour, 2 hour, and 4 hours of taking of ATT medicine. So, findings of undetectable drug levels, they suggested some issue with the absorption of the drug or metabolism in the patient. So in July 2023, in view of zero drug levels to rifampicin, PZA, levofloxacin, radiological worsening, clinical worsening, ATT regime was modified to include at least 3 injectable ATT drugs, including 3 oral ATT drugs. So this regime was devised with consultation of NRTID consultant Dr. Rufak sir and after our Dr. Naveed sir. Together, we had a discussion. So we started the patient on this regimen of 6 drugs, including 3 injectables and 3 oral drugs. Bedaquiline, of course, loading dose of 1 mg was started for 2 weeks, followed by 200 mg alternative per week. Moxi 400, linezolid was given injectable 300 mg, amikacin 500, also cyclosporine, clofazimine. So this is the X-ray of the patient before starting this regimen. You can see bilateral upper lobe infiltrates. There was no improvement before that. Now, these are monthly serial X-rays after starting this injectable regimen. It's an X-ray of first one August 2023, the other one September 23, and the other one is November 2023. We can see the improvement has started after starting the regimen after 1 month, 2 months, and 3 months. We can see the decrease in the consolidation in upper lobe, especially on the right side in November 23 X-ray. This is a CT scan of the patient before starting the injectable regimen. You can see a left upper lobe cavity with consolidation. This is also cavity on right side, and there is left right consolidation as well with bronchitis and previous bed. This is a CT scan of the patient after 1 year of this regimen. These 6 drugs, we can see the breakdown of cavity, decrease in consolidation. There is also decrease in the size of nodules as well. This 1 year after taking this regimen, 3 injectables and 3 oral drugs. Microbiological response on this modified regime, patient after 7 months of this regimen. The patient was negative in Feb 2024, April 2024, July 2024, and November 2024 cultures were negative. Smears were all negative from Feb to November 2024, which indicated a sustained microbiological clearance to regimen. So after having completed 1 year of these injectables, we decided to start patient on maintenance regime from July 2024. So injectable was stopped. Only we converted injectable linezolid to oral linezolid. Rest kanamycin and moxie was stopped. We continued patient on bedaquiline, cyclosporine, linezolid, clofazimine. Bedaquiline was, of course, continued 3 weekly as patients QTC were remain normal. So we continue with that. So weight trend over a period of 2 years. So the patient, especially in July 2023, she was 28 kgs of weight. Over the period of time, over almost 2 years, she gained 15 years on this regimen. She is now 43 kgs of weight. She has good appetite. She is doing as good as such. Clinical improvement, patient has significant weight gain from 29 to 42 kgs, which reflects her improved nutritional status and systemic recovery. No recurrence of hemoptysis or conscious symptoms has happened after that, which is suggesting efficacy to our current regimen and patient compliance. So current status, patient weight improved, renal hepatic functions are normal, neurological symptoms are persisting. We have attached her to neurologist or local neurologist here. He has the full evaluation until completion of the TB treatment. Our recent cultures of Feb, April, and May 2025 are all negative. This is CT scan of the patient. 27 January 2025. We can see the breakdown, the complete breakdown of cavity. There's also decrease in consolidation in nodules, and there is also improvement in the right side of the lung as well. So the short summary of the patient, a 23-year-old female MBBS student from Kashmir, initially presented in December 2021 with respiratory and conscious symptoms. Empirically started the ATT in Bangladesh. She came back to Kashmir and she had adverse reactions like hyperuricemia, arthritis, axonal motor neuropathy. INH and PZA were discontinued. Later, she again developed hemoptysis. So patient was put on 6-drug regimen under expert guidance: bedaquiline, moxie, linezolid, amikacin, cyclosporine, clofazimine. We were able to achieve sustained microbiological clearance. Cultures and smears were negative from Feb to November 2024. There was radiological and clinical improvement marked by weight gain from 29 kg to 42 kgs, absence of hemoptysis, normal renal hepatic functions. All the neurological symptoms are persisting but are under specialist evaluation. Current status: patient is on maintenance oral regimen, bedaquiline 3 weekly, twice weekly, linezolid, cyclosporine, clofazimine. Patient's last 5 cultures 3 months apart are negative, indicating excellent compliance and favorable treatment outcome. So this is our plan, and we solicit your advices for that. We are continuing pyridoxine high dose to reduce neurotoxicity from the cyclosporine linezolid. We are going to attach patient to neurologist for complete neurological follow-up after treatment stops. So we have advised the patient high protein and high calorie diet. We are giving her psychosocial support for post-treatment anxiety. We want to reintegrate her into her medical education and give her long-term confidence. So I propose to the panel, shall we stop the treatment, or any advices from your side and from our honorable professors and honorable seniors who what they want to advise to for the further management of the patient. Post, we are also planning post-treatment follow the patient. We are going to do culture post completion of treatment. We will monitor his post statistically, and we will be doing annual chest imaging after every 2 years. Thank you. Thank you all.
Thank you, sir. Very well worked up case and very well presented. Could you put on the summary slide, sir?
Yeah, ma'am.
Yeah.
This
So,
one.
yeah, we open the case for discussion to the House. If anyone has any question on the history so far, whatever is presented.
There's a question in the chat box.
Yeah,
please. Yeah, there's a question that
my one question to J&K team, as I can understand, there are many cultures were done and many of the later on cultures came out to be negative, but initially the culture must have been positive. Is there any DST done in this case?
Yes, sir. DST has been done at every point of time, both first line and second line. When the patient.
But it was not seen in the your cases.
Yes, sir. It's there. I'll get back to the slides. It's there. So we have every time we have done cultures as well as sensitivity to first line, second line drugs by LPA, and it has.
What was the result?
So it was sensitive to all the drugs. So here it is. It's
sensitive to all primary and second line drugs.
Yes. Here's the LPA, one of them.
No, I'm not talking of LPA. I'm talking of DST by
conventional culture
method. Because the culture has been done. So DST report must be available. What I believe.
LPA.
I'm not talking of LPA. LPA1 and LPA2 I'm not talking. I'm talking of DST from as a say phenotype DST.
Actually, the samples which are subjected to culture, when culture comes out to be positive, that sample we used to do an LPA for that only.
No. What I wanted to say is that report is somewhere available. DST report, phenotypic DST. I'm not talking of genotypic DST.
प्रसाद सर डॉक्टर मेरे ख्याल से सर फिनोटाइपिक करा नहीं है.
That's not
नहीं करा गया है.
That's not available, sir.
Culture positivity has been subjected to LPAs, not to phenotypic.
Yes, sir.
Because still even today we say the gold standard is a DST by phenotypic.
Yes, sir, definitely.
Especially in such a difficult scenario. What I am.
So the NRA has replied to your question saying that they did not have a phenotypic DST available with them at that time. So it was not done.
It was not done, no? Okay, say like this.
Yes. There are some questions in the chat box that we will take now.
So the first question is that the patient was having poor absorption with first line drug. So we have started with the second line drugs. And to overcome the malabsorption, we have augmented the therapy with injectables also. But the question is that how can we ensure the absorption of the second line drugs when the patient was failing on the first line drugs? So there was almost zero absorption in the first line drug. Could you answer that?
Actually, ma'am, when the patient before sending the drug levels to NITRD, we actually had referred the patient to gastroenterologist to see for any malabsorption syndrome. Actually, they ruled out all malabsorption syndromes in the patient. So actually, we were not actually able to ascertain what was the reason responsible for the patient not attaining the drug levels. That is why, since the patient's multiple reports came out to be negative for drug levels post intake of drug, that is why it was decided that the patient will be put on all injectable regimen. Actually, Professor Rupak Singla sir had advised even imipenem in addition to these drugs. But since the patient could not afford the drugs, it was not possible for the STO office to procure the all injectable. That's why we added 3 oral second line drugs to the regimen. And NITRD was not able to do a drug level of the second line drugs, which we were, the oral drugs which were started in the patient.
Yeah. You see this question regarding whenever patient is not responding and the blood levels are showing, like in this case, 0 even at 2 hours, 1 hour, 2 hours, 4 hours. So one thing is there that the drugs are not being absorbed. And we tend to do the basic test, which include fecal fat, the stool for parasites, stool elastase, these are those tests. But most of the time we find that we are not able to pinpoint the reason for this. That has been our experience also. Now the very good question is, in these cases, as I'll share also, we had published an article and based on our initial experience. So we had the 75 patients which were there in this. who were not responding to treatment, but every time you do the sensitivity, it was showing sensitive. So in these patients, when we analyzed, we found patients who come to us early, say within 5-6 months of this kind of phenomenon. So there, just by increasing the dose of the first line drugs, we were getting acceptable response, good response. For patients which come late, say maybe 7-8 months, 9-10 months or little late, there just by increasing the dose of the first line drugs, we were not getting a good response. Now the question comes, should we treat them as clinical failure and add the second line drugs? So again, this question, how are we sure that in case we add the second line drugs, patient will be absorbing these drugs? That's always a big question. So ultimately, then in the end, most of the time, even today, you see, doing the DDM to second line drugs is a challenge. Earlier also, and even today also, there are very few laboratories, maybe one or two, who are able to reliably do the DST for this, the DDM for the second line drugs. So what we do, like in this case, we try to use as much injectables as possible so that this poor absorption is taken care of, and rest of the drugs, which are not available in injectable form, like in this case, we had injection of moxifloxacin, we had injection linezolid, we had injection amikacin. So these were introduced. Even the discussion about the imipenem was there because by the time we had done the blood levels, patient has had a significant destruction of the lung in the form of cavities. And it's a young medical girl. Aim was to save the life of the patient and convert this patient. But as somebody said that you see the logistic challenges are there. It's not so easy. You insert a paralytic line, then 1 hour infusion in the morning, 1 hour infusion in the evening. The cost is also challenges which many people do not understand. They use it. So the team at I was also three injectables, and the other three like bedaquiline, clofazimine, cycloserine, for which injections are not available. So this was treated. So specifically, you see, because the TDM for the second line drug is not available, we tend to give injectable, and that was done in this case. Thank you.
Thank you, Dr. Singla. Dr. Jaikishan, sir, you wanted to ask a question? Sir, you are muted. Sir, we can't hear you. Please.
Sir,
जब तक आप unmute करते हैं, can I take question from Dr. Rajiv Tandon?
Hello.
Yes,
Hello.
sir. Yes, sir.
So, to my mind, this is a definite case where there is a delayed response. And delayed response, as already said, that it can be because of the lower concentration, and as it is proved also by the therapeutic monitoring. Now, what about the cause for these the lower levels? Whether there was intestinal TB which was ruled out or not, whether there were vomitings or not, whether there were some food infections or not. And in this patient, there was an initial response, the radiological clearing was also there, and then the cavity developed. So the later on, whether there was a concomitant infection with the NTM, whether we have already gone for the NTM culture also, since in this patient, once we started with amikacin, clofazimine, the patient started responding. So these are the issues which need to be tackled. And in a patient, medical student having these problems, the mental stress, the physical stress, that can also be one of the cause for the delayed response. So any comments on that?
Dr. Fahim? Dr. Fahim, you are muted. Yeah.
We should not have NTM because cultures were persistently positive. There are rough, buff, and tough colonies on the culture. We are continuous touch with the microbiologist on IRL. So possibility of NTM was not there because patient was AFB culture positive persistently all through these months.
Both can be together also, no? in a thoracic cavity, then the NTM can also be
Yeah,
growing. So
co-infection can.
whether we had specifically sent the cultures for the NTM or not.
We have not sent for NTM.
Okay.
NTM.
And regarding the malabsorption and intestinal TB, the patient's upper and lower GI endoscopy were done, and there were no features of any intestinal pathology in the patient.
And vomiting, any infections?
No, not at all. Patient just had neuropathy, perhaps due to isoniazid, and hyperuricemia, perhaps due to pyrazinamide. When the patient was started on the first line, when the patient had initially started the treatment.
So we continue to say discontinue with the isoniazid. So whether it was a must and the neuropathy is resolved or not, whether we could have started the INH again.
Well, isoniazid was stopped because patient had severe neuropathy. When the patient was on continuation phase, the first time the patient was diagnosed with sputum positive PTB. The patient was not able to move, but since then, the patient, since already had a neurotoxic drug, linezolid, the patient was put on paradoxin high dose, and post that, the patient is not fully recovered, but she is now able to walk. So neuropathy is still there, but it has improved as compared to what she was at the initiation of treatment.
Okay. So the patient was also having pregnancy. So any vomiting, emesis during pregnancy was increased requirement of the drug during pregnancy.
No, sir, she was not pregnant. She was an unmarried 22-year MBBS student. She was not pregnant. And second, she did not have any vomiting during the course of treatment.
Okay. So there was no pregnancy. Okay.
No, sir. No, sir.
Thank you.
Okay, thank you, sir. Urvashi ma'am, you want to say something? Urvashi ma'am?
Yeah, thank you, Roknita. One very, something very simple it may appear. What is the BMI of the patient? You said a young girl, 22 years old. What was the BMI?
Site calculated the weight of the patient at the start of treatment was 28 kg, 29.
Now that brings me to my point. You see, we talk of drug absorption, a great TDM facilities are few in the country, but let me promise you, before I finish my tenure, there will be more. In fact, with BPALM, we had vowed to also start doing therapeutic drug monitoring for all patients. Somehow that has not been rolled out. Currently, we have 2 to 3 centers, like Dr. Singla sir said. Now, a low BMI patient, we are not ensuring nutrition. I mean, by ensuring, I mean, we know that you are all aware that with a lot of effort, we rolled out energy-dense nutrition support for those with BMI lower than 18.5. Now, all the drugs for absorption will need, some will need protein molecules, some will need lipid molecules. Unless the patient, of course, the patient herself may not be taking adequate food because of anorexia related to the disease. Now, this is something we need to actually concentrate on to both ensure drug absorption, also to ensure the immune system recovery by ensuring nutrition in whatever form. If the patient can take their own nutrition, very well. If not, then we can give energy-dense, calorie-dense, protein-dense nutrition so that the patient also is able to absorb the drugs. Of course, the regimen which Dr. Singla sir has been guiding and the team, I'm sure, is efficient themselves. But of course, I couldn't really pay a lot of attention to what regimen, but then we follow all the guideline principles that not to add single drug to a failing background regimen and all those things. But I do agree when Dr. Prasad sir also asked, unless we were sure it is not drug resistant, why did we move to second line? We could have looked for ways of sticking to first line and ensuring that the drug absorption did happen. So that could have been one more angle to this. But the message all across is we must stress on nutrition, if not for anything else, at least considering it as therapeutic role. So EDNS is a therapeutic nutrition. We have rolled it across the country. The states have been advised to procure. This has been put on GEM. There are 5 or 6 manufacturers. But this is something we all must stress on. Low BMI must get EDNS. Others get, nutrition. So the TB health visitors, the senior treatment supervisors, also champions. I think you mentioned champions also supervising the patient's recovery, that the patient gains weight, the patient is feeling well, he or she doesn't have any side effect. If he has, then the follow up with the physician should be ensured. So all these should be done on a periodicity, maybe weekly, so we know exactly how the patient is improving and we do not lose this much time possibly to treat a DSTB patient. Thank you.
Thank you, ma'am. You brought up a very important point. Next is Dr. Rajiv Tandon. You've raised your hand.
Yes, my question to Dr. Naveed is his observation in this patient regarding such a prolonged administration of amikacin and whether or not regular audiometric follow-up was done in this patient, because this is a rare scenario when we go for amikacin for such a long duration. So your observation, please. Whether the child did have any phototoxicity or not.
Yes, sir. We have regularly been following the patient. He is being sent to neurologist, ENT people, and nephrotoxicity and hepatotoxicity are evaluated at periodic levels in this patient. She did not have any autotoxicity. The only issue with the patient was neuropathy. That was the only thing which had happened, but that was existing prior to starting of the treatment. And that has progressively improved as the patient has taken treatment. The patient's neurological status has improved, the weakness has improved. She is now able to walk and do her at least a routine activity she is able to perform right now.
So there is no hearing loss in this patient?
No, sir, no, not at all.
Okay, thank you.
Okay, thank you. Rajendra Prasad, sir.
One more question I forget before I say in the end as a national. So, but what was the status of HIV? I might not have seen in the.
So the patient was negative for all. Triple serology was done. The patient was negative. Okay. Patient did not have any other comorbidity along with this.
Okay, thank you. And second thing, some question was raised by Dr. That whether the culture for atypical microbacteria, if you do a culture, I believe, since Urvashi Singh is here, and if you do a culture, if it is NTM, it gives some idea from the culture itself, because most of the NTMs are early growers. So usually the microbiologists, they say that possibly there is an NTM and then you can go ahead. So same culture can tell what I have been taught and what I little bit know about microbiology.
So very true. Non-microbacteria can actually create confusion, but the traditional people do not look and assume any culture grown is TB. So it's important to confirm it's TB. Non-tubercular microbacteria can present, can actually colonize cavities and eventually cause disease. It is not difficult. In fact, the LPA is also available for NTM now, doesn't pick up all species. And when there's a culture speciation with current capacity across the country to do molecular work, including sequencing, target sequencing, whole genome sequencing, it's across all. And I am sure if the facility themselves, like for example, when they said phenotypic DST was not available in the IRL, which was at that time, now we have 50 labs who are doing even DST to bedaquiline and pretomanid. In addition to linezolid moxie, which we have trained painstakingly, they are undergoing external quality assurance. So our strength is increasing. Same labs who are doing culture can very easily do speciation. And frankly, we are aware that earlier on we used to have MAI, Kansasai, and abscesses. Now in India, at least we're finding abscesses more frequent. It is difficult to treat, but yes, we must treat it carefully with the prescribed regimens And that is why this question is important for everyone. We must rule out in existing cavities. And also, I've spoken at earlier occasions, in fact, publications in IGTLD also, where co-infections of NTMs with MTB could also be present. So diagnosis to the last, we must know the complete diagnosis to deal with it carefully. Thank you.
Thank you, ma'am. We have some questions on the chat.
There's one more question in the chat box. Actually, it's not mentioned in the guidelines anywhere. In what all conditions we can continue Vidofludimus in CP phase? Could you take that up? The condition in which we can extend Vidofludimus apart after intensive phase or in the CP phase. Dr. Rajendra Prasad, sir, can you answer this question?
I think if you cannot use other drugs, they are required, and then probably extension is being done. Other drugs are not possible to be used. But here I think we are using. So there's a lot of more questions are there since this we are using the second line drug. How much drug to, that was the question they have posed. Probably we have to will be probably be more useful for saying, and then I will also comment as a national expert.
Sure.
So, are there any other questions? You have no questions?
There's one question from Dr. Yusuf here. Good afternoon, everyone. My question is that in this patient, there was early development of neuropathy in this patient. So as we say that rifampicin and are quite inducible, or they can be blocked because of cytochrome enzymes from the liver which influence their metabolism. So is it possible that we can do urine levels of urine metabolites of the drugs that we can confirm that there is no absorption defect actually, rather than there is immediate, enzymatic involvement and decreased level in the blood? Can we do have in future such like urine metabolites so that we can confirm that it was because of various liver enzymes? Maybe there's genetic polymerase in a patient that may decrease actually the levels and we cannot detect in the blood. This is my question. Am I audible? Is my question audible?
Sir, it was not very clear. Somebody can repeat your question because your voice, maybe you have to be little away from the mic. It's loud.
So my question is that in this patient developed neuropathy very early on with the DT, and we know as these various drugs, they are influenced by the liver enzymes, both INH and rifampicin. Like if patient is on anticonvulsants, there may be different level change in the body. So is it possible we can have in future urine metabolites of these drugs to be monitored so that we can know that actually absorption defect is not there, but there's early serum, what we method we use, maybe it is low to be detected by a serum level method, and we may, if we have urine metabolites that consultation is taken, but levels are not achieved because of enzymatic activation from the liver.
Sir, we are still not clear with your question. Can you write it in chat? It will be clear.
Ma'am, I would summarize it. I would summarize the question. The question is that if the patient is taking the drugs regularly, we are not achieving the serum levels of the drug. So is it, he means to say that can we have a urinary test where we can detect the urinary levels? Maybe the serum levels are not detectable by the method what the lab has used, and we can detect the levels in the urine to see whether the patient had taken the drug or not.
I think is Dr. Urvashi there? Ma'am is looking into this. Dr. Urvashi, ma'am?
Ji, Doctor, I missed the question.
Sir, ma'am, they want to know that when we are doing TDM, we need serum. Is there a test coming which can detect the drug levels in urine?
Well, I wish we were ready with such a thing, but not yet, sir. But thanks for the idea. We'll work on this. Maybe we can. But then it is important to actually look at the site of action. So blood, of course, in extrapulmonary sites, we know that the levels that reach in pulmonary sites are not always equivalent to the levels reached in extrapulmonary sites, bones, CNS. So again, we can safely use TDM to help us know the um, know the levels that may be reaching tissues where vascularity is good. Let me tell you, our own study in TB meningitis showed very poor levels in CSF. So we looked at CSF levels. So again, this can be a good parameter for those organs where pulmonary, for example, for which are good vascularity, but not for extrapulmonary. But nevertheless, also urine will not actually show us. It'll only show us the filtered out. So although it may appear, easier, and like I said, for till now we don't have anything in hand, but we can work on it. But it'll still be best to look at the concentrations, because it includes in blood. It'll include, we can look for bound drug as well, and free drug also. So, because the drugs, like I said, will bind to protein molecules, will bind to lipid molecules, and you're aware of bedaquiline long half-life because of the binding. So there are tricky issues around drug levels. But yes, we can look at if urine can be helpful. Thank you.
Thank you, ma'am. Are there any other questions? Any comments from the state expert? Dr. Farid, sir, any comments?
The query remains that we have now got around 5 cultures which are negative, and the patient has completed treatment for more than 1.5 years now. So, what should be the plan? Should we stop the treatment because it's a very sensitive issue? Because the patient who was in her third year of MBBS has fortunately been told that she would be allowed to continue her studies, which is against norms. So the question is, should we stop the treatment and allow her to go back? And how should be the patient monitored in future to see for any recurrence? And what the neurologist is already taking care of the neuropathy at present.
Right, sir. We take. Sir, comments from you, Dr. Prasad, sir? Dr. Rajendra, can we have your comment?
Yeah. So, Nita, thank you for asking my comments, but I'll be very general while commenting. That one thing, if I see that she is a medical student, about 23-year-old, and if I see the initial history, her Mantoux test was done, but the sputum was not done. That probably this is the JNK people. In the future, your lessons when you.
Sir, may I interject? Actually, this was diagnosed in Bangladesh, not in Kashmir. The patient's the treatment was started in Bangladesh only.
So in Bangladesh also probably they need more education, and that ideal test to diagnose TB is the bacteriology or molecular biology, not the Mantoux test. That was the one what I thought. Then second issue was I am still unable to understand why there was a malabsorption, because from the history it was not evident. So one has to be very careful, because if say there is a malabsorption of the first line drug, why in future even the second line drug may create the same problem. Somebody has raised question also, and unfortunately we hardly have anything to say about the therapeutic drug monitoring of most of the second line drugs. So that is another question comes to my mind. And the third very simple question, during my MBBS teaching, my teachers has told me that the dose of pyridoxine, and we have also taught that to prevent the peripheral neuropathy is about 10 milligram. And if the peripheral neuropathy has occurred, especially with the isoniazid, because those days linezolid was not there, then the dose is higher. And what we have been told, 200 to 400 milligram of pyridoxine one can go. And we have used in some of the patients, we have seen that the peripheral neuropathy, there's a difference in dosing. So that may be another point if we really, a neurologist may be consulted, and if the dose of pyridoxine instead of 50 can be increased more. And what the third point I would like to say, that what Urvashi Singh has already said, that the young lady who was, I don't know what was the socioeconomic background, what was the financial status of the lady, but she was a medical student studying in Bangladesh. So she was having a severe, I think BMI was less than 18, so malnutrition. And so his nutrition has to be, I mean, keep in mind every time. And probably the gastroenterologist and people has to be consulted why this has happened in this girl. So that was the another point of view I had to raise. And if I can go to my old good student days, my boss used to tell us there's a fall and rise phenomena. Fall and rise phenomena was it was just contrast. Here initially we don't know what was the sputum. So they say that fall and rise, there were two reasons of fall and rise phenomena. One is either a patient has stopped taking drug, and another reason is if there is some drug resistance. So anyhow, the drug resistance, as we see all the reports, there was not there. So this point also has to be kept. I mean, sees a case for a good counseling. I don't know the patient, but I can quote one example for the listeners. I'm talking when I was in KGMC way back in 90s. I was head there. One of the medical students from Meerut came to show me, and as similar case, he was not responding. In 90s, there was no question of therapeutic drug monitoring. My PG took the history, and PG said, sir, she is very compliant. Because, and then I took the history myself, and initial history was also to me that she has been very compliant. This I was talking with the father and mother both and the patient. It came to my mind why she is not responding. So ultimately what I said, I requested father and mother to please stay away for some time. I would like to talk this. She was a young girl, about 18-year-old, 18, 19-year-old. So I said, and what was you will surprise what was the answer by the girl. Girl says, sir, my mother used to feed me these tablets. But since I had some vomiting, nausea like thing, so माँ मेरी खिलाती थी, हिंदी में मैं बताऊं अगर सब लोग समझ रहे होंगे, माँ तो मेरे मुंह में डाल देती थी और मैं बाथरूम में जाके इसको कुल्ला कराती, फेंक देती थी. So although this is a rare situation, so compliance and counseling, these are sometimes are very important, because I'm unable to understand why patient has not responded, except one reason, that the drugs were not being absorbed. That if the first line drugs were not absorbed, how we are going to ensure? Please make sure that second line drug, though she has responded beautifully, what I say. The last thing, the question, I think it will also be supplemented by Rupa, that how much treatment now? I hope if I heard correctly, Nave telling that she has already completed this 3 injectables and bedaquiline-like regimen for 1 year, more than 1 year. How much treatment she has taken with this revised regimen?
18 months. So it's more than 18 months now. It's almost nearing 2 years.
Means revised regimen, what we revised, the 3 injections, including bedaquiline, clofazimine, cyclosporine, 1.5 months, 1.5 year. So I think, and CT also shows that she has responded. Bacteriologically also says she has responded. So suppose one has to maximum treatment, to my understanding. I don't know with the second line drug, with the primary line drug, we say that usually it is 2 years maximum. But then when you stop, one has to be very careful. She is likely to relapse, and counseling is very, very important. And I think the you must have taken some gastroenterologist opinion. Why there was malabsorption? What was the reason? Is there some specific reason, some enzymatic reason? I mean, this is something to be discussed. So, and the follow-up of this patient is also very essential. Now I see hardly any, very little residual lesion is there. So follow-up is definitely essential for such patient. And patient has to be told, patient and family both has to be counseled regularly, that she has to, and I think Rupak will answer more up to what time we can continue these drugs. Thank you very much.
Thank you so much, sir. So now I would request Dr. Rupak Singla to give his comments. But we also have 2 questions that you will need to answer. One very interesting question is that you have 0 levels on TDM, but at the same time you have toxicity with this drug. So it's like, again, a very complicated puzzle, as the title of the clinic was, a therapeutic puzzle. So one way we are saying that there are
can I comment here? Basically, when the patient was started on 4 drug initially, when first time, the patients had responded to the treatment, and at that time only the patient developed neuropathy, not after that. So probably initially there was absorption, the patient responded to the drugs, at the same time developed complications, and then she stopped responding. Perhaps she was not absorbing the drugs, probably after around 3 months of initial treatment, when she had started to respond to the treatment. Because radiologically, bacteriologically, clinically, the patient had responded in the first 3 months of treatment. And at the same point of time, the patient had neuropathy, not later on.
Naveed, one thing I would like to ask, compliance issue has been addressed very
yes, sir. Yes, sir. That's ensured. The patient was quite compliant with all the treatment at every point of time. And in the regarding your question regarding the malabsorption, even the gastroenterologist, after doing all the investigations, they were not able to ascertain the cause of malabsorption.
Okay.
Right, so thank you. So, Dr. Singla, there's another question which I think you can cover, is can we consider a high dose of rifampicin if the TDM shows that there is lower level? So can we increase it? Yeah.
Okay. So today's case is definitely, as always, it calls for introspection also, what is happening, what we are doing is correct or not. And these cases are not very uncommon. We are seeing them more and more as we are enrolling more and more patients. And many questions have been raised, and I think, like Dr. Ruchi has emphasized enough about the role of malnutrition. So if there is a malnutrition, we must take it very seriously, and whatever medicine we give, whatever investigations we do, we need to simultaneously ensure that patient is having a good nutrition, because this helps in building the immunity also, and the absorption can also be improved by improving the malnutrition. And Dr. Narendra Prasad sir, we all know he has almost 50 years of experience in the field, and compliance, he always emphasizes, and which has a meaning. What case sir has described is very often in case need to go into details. Patient says, no, the taste was so bad, like most of the time I was not able to take it and I used to spit it out. So you see in the olden times when the streptomycin, INH and PAS was the treatment, we were told that all the grass outside the windows used to be pink. The reason being PAS is very difficult to be tolerated. Sister used to give it to the patient in the sanatoria, the pass and they used to throw it out. So the entire greenery around the windows of the ward that was pink because of this. So these compliance issues are known. Unless we focus upon them, this basic thing will be missed. Whatever medicine you give, patient will not respond. But here, Dr. Naveed's team, they have been very, very careful about this. Right from the beginning, when we discussed the case, first thing he said was that patient has been compliant and they have checked it very well. So that part is also important, but taken care of in this particular case. So if you see this case, other ones also I'll come to. So this is a 23-year-old MBBS student. In the beginning, respond to be rifampicin sensitive and put on conventional 4 drugs in December 21. And then within a month, she started having joint pains, hyperuricemia, and the treating physician, they decided to stop the pyrazinamide in view of this. And the next month itself, patient had symptoms of peripheral neuropathy. And the nerve conduction studies, they showed axonal motor neuropathy. So the INH was stopped and patient was put on this rifampicin, ethambutol, and levofloxacin. And as you all know, the INH-induced neuropathy is typically sensory, bilateral symmetrical sensory, and sensory motor. But axonal motor neuropathy can occur, but very, very rarely. But in this case, the team had involved the neurologist, a senior neurologist of the state, and he had advised that no, you level it to INH and referred to them that please don't use INH. So they decided not to use INH of this case. So, but in the bargain, what happened in the beginning of the treatment, in the first 2 months, which is very, very critical for the so-called the intensive phase, we lost 2 good drugs, that is INH and rifampicin. And the team had to resort to giving this patient rifampicin, ethambutol, and levofloxacin, which is definitely not a very, very, very good regime, but I think the team was cornered in absence of this. And they wanted to give as much first-line drugs as possible to begin with. Next. So now in July 22, that is almost 6-7 months after this treatment was going on, patient started having hemoptysis. The X-ray deteriorated. It showed cavity. Sputum culture became positive, and it again showed HNR sensitive. So in this case, keeping this thing in mind that patient is not responding to the existing drugs, the team decided to put the patient on rifampicin, ethambutol, levofloxacin, which she was continuing earlier, and added streptomycin and pyrazinamide, so that now she was on the 5 drugs. Although again, this can be discussed that 6-month patient has taken 3 drugs and deteriorated with the sputum being positive. Whether addition of these 2 drugs was sufficient or not, ideally we should have had more drugs so that otherwise sometimes just adding 2 drugs in a regime which was failing, we have our own doubts whether this will work. So anyway, this was done. And also I think in India, the primary streptomycin resistance is quite high, although it's not being used now. So in such scenarios, we may prefer amikacin instead of streptomycin. Having said that, in February 23, the sputum cultures were positive, but again, sensitive to INH and rifampicin. Then May 23, the TDM was done. I must appreciate, you see, it is easier said than done. Doing a TDM, sitting in Srinagar, sending it to NIRT Chennai, it is not a joke. Sitting in Delhi, where we have very good courier system, even because we have been sending to NIRT almost 6, 7, 8 years. Only for last 1 year now we have our own laboratory working on this. It is a really big challenge. You need a good courier service. They want, like in Delhi at least, they said, sir, give us the sample before 1 p.m. so that if you want it to go the same day. In case it doesn't go the same day and it has to be in the cold chain, sometime by the time the sample reaches there, say 3rd day or 4th day, the sample is spoiled. We have faced all these difficulties. Once we gave the sample and he got late to collect it, and again this was shipped from here 2 days after that, and by the time it reached there, sample was spoiled. Another occasion, they picked up the sample, sent on time, but it reached there on Saturday. On Saturday, the NIRT is closed. But so nice of them, we called them, they came, they opened the laboratory and put it in the deep freeze. So this kind of cooperation we have been getting from them, but it is definitely an issue transporting the sample in a cold chain right from the source to the laboratory. But still the team, I must appreciate, they did not only once, they did it twice. In the first time they did, it was found to be 0. And then they did the next time they did 0 1, 2, 4 hours, and every time they found non-detectable. Next. So now with this background of patient not responding to treatment and the level showing this non-detectable levels. So here you see, I would like to go back. We were having the same issues, and when we were because we were being a referral site, patients were being sent to us who were taking treatment. Lab saying repeatedly sensitive, but patients were not responding to treatment. And once we had collected around 74, 75 patients, we tried to put them together. And what was happening? So what we found was that in among these cases, on univariate analysis, we found that the lower BMI has already been discussed, the hypoalbuminemia, the viral disease on the chest X-ray, and the presence of cavities. They were significantly associated with the low drug level. Although multivariate logistic regression analysis, they were not found to be, but on univariate, they were found to be significantly associated with the low blood level. And when we looked at the response to the treatment, whatever was given, same factors were there which showed that if these factors are there, response to the treatment may also not be good. So, and this current patient, she had all the risk factors which are mentioned above. She had low BMI, she had hypovolemia, she had bilateral disease, she had the chest X-ray cavities. So this was the likelihood of a poor response to treatment was there in this case. Next is, you see, but as like was being discussed, that what was the reason for malabsorption? So let me tell you, we are lucky in Delhi. We have good friends in All Institute of Medical Sciences. We had approach to the gastroenterology. Dr. Ahuja was there. Then in the infectious disease department, now Neeraj is there. They all cooperate with us. So whenever we used to get this investigated, they did like common tests, like they did the fecal fat test, the stool elastase test, these are those absorption tests. And the Dr. Ahuja, I remember he had done even the duodenal biopsies because they say to look for the celiac disease, tropical screw, Whipple disease, things like this. They need biopsy, and if it shows villus atrophy, celiac disease can be sort of considered. But in none of the cases, wherever we could do it, we could find anything which can say that this is the reason for the malabsorption. So that is a field reality that it happens. We expect them to have some positive finding, but most of the cases we do not find any cause or any etiology that can say this is because of this. Yes, some people they have the worm infestations. We give them deworm in almost all of these cases. The common thing is even the GRD infection can also be there. So we give to treat that also. But most of the time, what I want to say is that we don't get a reason etiology for malabsorption. Now, second observation was you see this team, so dedicated team working in a tertiary hospital. They were thinking of it to do this non-response to treatment, but still it took almost 1.5 years for TDM to be done for the first time. Again, it indicates the challenges which we face. First of all, sometimes it doesn't come to the mind that yes, this could be the reason. Second is, even if this comes to the mind, you don't know where to go, how to collect the sample, where to send the sample. So this also across the country, we have to learn it. You see, unless we get it done in 1 or 2 cases, everybody is like this, that we feel, no, it cannot be done, and we keep on trying. But once we do it, next time we feel more confident when to do it, how to collect the sample. Because even the sample collection, it requires some sample 3 ml, then centrifuge this, take out the plasma, add 10 microliter of 5% ascorbic acid, and then again you transport this in a small void in the cold chain. So what I'm saying is every step needs some care whenever we try to do the TD. Next, please. So then we coming back to this case from July 25 to 23, patient was on 6 drug regime, that is oral bedaquiline, injection moxifloxacin, injection linezolid, injection amikacin, cycloserine, and clofazimine. So in this our own observations, we also found that if we receive the patient, say within first 6, 7, 8 months, that he has taken treatment only for this period and is not showing response to treatment, and the blood levels are also low, we used to just increase the dosage of the first line drugs, and we could find majority of the patients were doing well. However, in patients where they have taken treatment for say more than 9, 10 months, 11 months, 12 months, there, just by increasing the dose of the first line drugs, it never works. What we found, it never. Yeah. So whenever you see, we find the blood level has been done and is non-detectable. Our the message to us was that in these cases, do not rely on the oral drugs, whether you are able to find the cause of malabsorption or not. Give as much injectables as possible, at least the blood levels is ensured. So in this case, injection moxifloxacin, which is available in the country, injection denosumab, injection amikacin, that was given. So that 3 injections. And second, as this is for Dr. Urvashi to reply to her this thing, that we had given enough prior to the first line drugs for 1.5 years. So now continuing with the first line drugs, as clinician, we felt that is not going to help us. Already patient has used this for 1.5 years. So we decided to shift the patient to second line drugs as a so-called clinical failure case. The laboratory is not telling us it is resistant, but patient has failed to the drugs. And even the X-ray has shown deterioration. So in these cases, we definitely add the second line drugs. And sometimes we try to retain the high dose of first line drug. Now in this particular case, the INH was not tolerated from the beginning. So there was no question of retaining high dose INH. Second thing was retaining rifampicin high dose. Now we all know rifampicin has drug-drug interaction with bedaquiline. It can significantly reduce the levels of bedaquiline. And here we were not to see the screen. So in this case, we had to choose between bedaquiline or between a high dose of rifampicin. Because patient has used this drug for such a long time, we decided not to give high dose rifampicin, rather put the patient on bedaquiline, which has a very good sidal and very good sterilizing effects, so that we have a good regimen from which we can expect patient to be responding. And regarding this, which we have already discussed, was adding injection imipin and chelastatin. We all know this, the logistics we have just discussed also. The cost, insertion of the PICC line, requirement of the infusions at home, these things are not that easy as it looks to be. So that option was not considered in this case. Now, we reached July 24. And at that time, she was on a maintenance oral dose, that is bedaquiline 3 times a week oral, linezolid oral, cycloxane oral, and clofazimine. And by this time, she was shifted to the oral drugs. The repeated cultures in the last 1.5 years or so, 3 months apart, they were all negative. Patient was clinically doing well. She was gaining weight. Now, about this follow-up regime, what I feel that instead of the retaining clofazimine, I might have retained moxifloxacin. Number one, it is a paid drug. If it is effective, it is very effective. And second major reason is clofazimine. You see in a girl from Srinagar, they are fair, and they are more like, and now she has already received clofazimine for more than I think 1 year. So it leads to all the skin changes, brown discoloration, the scaling of the skin. So considering that point also, I might have preferred to retain moxifloxacin rather than clofazimine. But we also know that clofazimine is a good sterilizing drug. So I think the treating team took the call to retain clofazimine, which is scientifically very much correct. And after that, as has been told, patient has repeated sputum cultures negative for last 1 year, clinically improved, has gained weight significantly. Symptoms wise she has improved, but this neuropathy is persisting, for which they are in touch with the senior neurologist, and she is getting symptomatic treatment. And they are also taking care of the nutrition of the patient. And CT scans have also shown significant improvement. The cavities either reduced in size or they have disappeared. Now the next question comes, what next? As Dr. Naveed has also asked that they want from the house, anything else we can suggest? First is, as everybody said and discussed also, a very careful follow-up is required. These are the cases, as Dr. Ranjit Prasad said, the likelihood of relapses are there. Once we leave the patient who has had poor drug absorption with cavities, we are always afraid that they might relapse. And sometimes we are not even sure how much the drugs has gone to the walls of the cavities. So they may not be any sputum positive that time, but there may be few bacteria persisting there which can cause the recurrence. So we have a very strict follow-up of maybe every 3 to 4 month X-ray in the beginning, and at least every 3 months sputum smear and culture. That must be done. Also, we should keep the possibility of surgery. What I am saying is keep the possibility should be considered In this case, of course, she has bilateral lung lesions. So surgery as of now is not to be considered. But otherwise, in general, in any case, at least keep the possibility of surgery, whether it can be done or not. And then you see if you feel it can be done, it should be done. Then you have to see whether the patient is fit for surgery or not. You may feel that patient has an indication of surgery, but then you find no, the patient is unfit for surgery. So that is also to be seen. So good nutrition, follow with the neurologist. Then for symptomatic treatment, she needs to be taken care of, and follow up with the cultures and the X-ray. This is the thing which we have to do in this case. And also, if you see as Dr. Rishi has said, the promise that soon we are going to have this TDM facilities. I think ever since she joined the Central TB division, she herself is a very good researcher for the TDM. So she knows the importance, she knows the challenges that it should be there, and she's trying her best for this. Issue is that you see even this non-recognition of the possibility of low blood levels. Sometimes, rather majority of the time, we have seen that doctors don't even keep in mind that this could be possible. We keep on doing the other things, keep on doing the test for the sensitivity and this, but this fact that it could be because of the low blood levels doesn't come to the mind. So for this we need the CMEs. We request the professors of the medical colleges to please inform their colleagues, inform their students that this possibility should be kept in mind when there is a no response or delayed response. Logistic challenges we have discussed, they are there, they need to be taken care of. If we have more number of centers in the country, the logistic challenges will be reduced. And very big issue is the TDM to the second line drugs. In this case, in case we knew that we had the availability of TDM to second line drugs and they were absorbing second line drugs, there was no need to go for injectable, the second line drugs. Well, now we are lucky in our institute, they are starting to standardize the TDM to the second line drugs. In those cases, in case we find second line drugs are being absorbed, then we can take a call whether to give oral or injections are still required. And also, like we shared our own experience from this institute, better to refer the patient early. In case we catch these patients within first 6-7 months that they are having low levels, they are still sensitive, just by increasing the dose of the first line drugs may suffice. I'm not saying always, but it may suffice. But once we delay, say about 10 months, 12 months, then chances of response of the patient just by enhancing the dose of the first line drugs, at least in our experience, we find no. Most of them, they did not respond if we are just increasing the dosage of the drugs. We had to give them 3-4 second line drugs to expect a good response. So that experience also we want to share with you, that try to catch them early so that an early intervention it can be done. And I must thank the Srinagar team for their perseverance to manage this case. And they were always in touch. We were used to talk on phone also, and they shared the patient also, but they kept on trying. I was also watching. They are with this patient for 3 years now, and they are giving their best of knowledge and experience. Now, since the patient has almost received, I think, more than 1.5 years of treatment, so it is time that normally even in the all longer regimen, we give for about say 18 months to 20 months. So now we can take a call to stop the treatment, but keep on monitoring the patient and follow up regarding the clinical status, the radiological status, and this. That is what I feel. I'd like to request Dr. Arindra Prasad for his opinion also about this.
Thank you, Dr. Singla. Dr. Ma'am has raised her hand for quite a long time.
I agree with Dr. Singla that since he has completed about 1.5 years of this revised treatment and culture and radiology, clinically, everything she has improved. So this is ideal time. We may stop the treatment, but only I'll caution that a regular follow-up is essential for this. And they have to told very clearly that you have to be regular, and by even if she has to go even to the CT, I mean regular follow-up, at least minimum with X-ray and sputum, and even if CT is required, that can be, but because that early changes will probably be more visible in CT scans. As you see in the first CT scan and in first X-ray, lesion appear to be only on the left side, but the first CT has shown that lesion is bilateral. So CT would be much better way to follow up in this particular lady. She's a medico, she can do the things. Thank you. Thank you, Rupa.
Dr. Singla, there was one question for how long bedaquiline can be given. I'll take that, but I'll take comments of Dr. Urvashi ma'am first.
Yeah, so let's finish about bedaquiline and then I'll come in.
Yeah. Thank you, Dr. Uchi. You see, guidelines are clear, and also the general practice also. We try to stop bedaquiline at 6 months as a routine, but in cases where we find we are not able to have a good regime in the continuation phase with this existing first and second line drugs, sorry, the group A and group B drugs, then we tend to increase the duration of bedaquiline. Like in this case also, to have a good continuation phase so that she completes 1.5 years of treatment, it was felt necessary that we continue with bedaquiline. Otherwise, shifting to oral and without bedaquiline, we had limited number of drugs. So the decision was taken to continue bedaquiline till the end of treatment.
Thank you. Thank you. Yes, ma'am. Over to you.
So, sir, classically the non-tubercular mycobacteria could have been a culprit. Considering the patient had initial cavities and, so I wanted to stress on the diagnosis of non-tubercular mycobacteria, and all microbiologists should also ensure where possible. We can follow the IDSA guidelines, the ATS guidelines. And the treatment like was used here could also be okay for non-tubercular mycobacteria, but the American Thoracic Society clearly lays down which non-tubercular mycobacteria and what drug regimen should be given. Not all ATT will act on all non-tubercular mycobacteria, so that bit of information is very available very comprehensively in the 2007 guidelines. For pulmonary, we have 2020 guidelines again, which are very helpful. But frankly, at AIMS, we have found several such cases who were non-tubercular mycobacteria over a past cavity or something. And the recommendation is to keep them culture free. So the treatment has to be continued at least for 12 months after the last culture grew. So I'm sure in this case, all that has been followed, though with TB in mind. We can keep this patient under careful follow-up, like Dr. Prasad sir said. X-ray, again, we have been reiterating because this is something which is not being practiced regularly with all patients who are completing TB treatment also. End of treatment X-ray, end of treatment culture, end of treatment clinical examination at 6 months for every patient is going to be mandatory soon. Without that, the patient cannot be laid off treatment. We will make that mandatory because this practice is no longer being followed because the choice was left to the treating physician. The bottom line remains that recurrence or relapses can best be caught before calling the patient cured or treatment complete, which in itself is a misnomer and misguiding term. The treatment completed, I mean. So it is important to call the patient cured before he's laid off the care. Post-treatment follow-up, everybody is stressing on cultures, but let me tell you, a lot of physicians say that sputum production was not possible, so they never did culture. If the culture was not being done, at least a thorough clinical examination and an X-ray is the bare minimum every 6 months for at least 2 years. Now, in case of non-tubercular mycobacteria, since I mentioned earlier, colonization is one of the factors which can exacerbate. So such patients should be very carefully followed a little longer. We have had patient losses even after the patient was cured, and this was published also. Patient was cured, culture free for at least 1 year post-treatment completion as well. But after that, he had a sudden exacerbation and we lost him, a young patient. The bottom line being non-tubercular mycobacteria can be very tricky, and a careful follow-up will ensure that the patient remains disease-free. Thank you.
Thank you, ma'am. Yes, Dr. Navid, you wanted to make it. Yes.
Yeah, ma'am. Now there are two things as we see that Dr. Rupak had mentioned regarding continuing moxifloxacin in patients. So after we have decided that we'll stop the treatment, should we continue moxifloxacin and for how much time? Point number one. Point number two, how frequently to do cultures in this patient, how frequently to do radiology in such a patient, and if there is a role of bronchoscopy if the patient is not able to expectorate sputum. So we can subject the bowel to mycobacterial culture.
Yes, Dr. Naveed, first of all, since we are deciding to stop the treatment, now whether moxie or not, we should be stopping the treatment. I was saying that earlier, instead of clofazimine, we could have continued with moxifloxacin. But anyway, that is already. One is to stop the treatment altogether. Second is to follow the case at least once in 3 months, clinically, weight, simple X-ray of the chest, and sputum examination for smear and culture. In case we find patient is deteriorating, X-ray is not sure doing well, then in that case we can do the induced sputum. And as you said, only in that case, if required, patient is not having sputum but otherwise not responding, then BAL can be done, not otherwise. In routine, we'll follow up with the clinical examination, weight charting, the X-rays, and sputum examinations. And as Dr. Rajendra sir also said, in between, X-ray will also help us. But if we find that at any stage we feel X-ray is not that much contributory, then we can even keep the possibility of treating the CT scan also. But she is a young girl and CT scan has been done. So we'll keep that thing in mind. But if required, definitely CT scan should also be done. And of course, the nutrition and the care of her neuropathy. These are all important points in that further planning. And we would like to hear from you, say 1 year down the line, what has happened to this patient. And sir, अब अपने श्रीनगर में भी आप थोड़ा पीछे पड़ के TDM का फैसिलिटी करवाइए, because TDM from Srinagar to us or to Chennai is a big challenge. So I think you'll have to be after Dr. Urvashi to give TDM first to you, then to any other place. That is my suggestion to you.
Thank you, sir. Because some of this, as you already told, that the threshold for sending samples decreases. So, post that we have sent 3-4 more samples to, and strangely, we got another patient with the same result. That although not all the drugs, but she was having a decreased level to probably isoniazid or rifampicin to a single drug, and she was not responding to the treatment. And regarding weight, sir, as Dr. Rajendra Prasad sir said, that the weight of the patients was not fair. She was not malnourished previously. When she had started with the disease, she was 44 kgs. Subsequently, the weight reduced to 28 kgs during the course of treatment. So probably it was because of the disease per se that weight has decreased. But now she has regained it back to 44 kgs.
Thank you, sir. Thank you for bringing this therapeutic puzzle to us so that we all could learn from this. So thank you, team Srinagar, for such an interesting case. So what I could learn from this case, for the patients who are not responding to treatment, in this case, you got your puzzle right in place because you had the TDM facility and you could, get to the reason, what was the reason for not responding. But not all have this facility as of now, so that facility is yet to come to everybody. So till then, whenever there is a patient which is coming to us who's not responding to treatment, what Dr. Rajendra Prasad said was that, we should rule out comorbidities, we should rule out TB of any other site that may be present. Dr. Urvashi said that, look for BMI, nutrition is a very important part of it. So undernutrition or low nutrition has to be seen and it has to be supplemented. Co-infection with NTM, that's a very important thing that has come up. So we have to work up patient for the co-infection. Then Dr. Rajendra Prasad said about role of counseling, that every patient we should be able to spend some time and do the counseling of the patient before starting treatment, during treatment. We should be helping this patient. And Dr. Singla stressed importance of TDM. If possible, we should be able to do it. And of course, possibility of surgery. If in some patient we have that possibility, we should keep that possibility open and look if we can do the surgery. And keep a watch on ADRs. Try to detect them as early as possible and take care of the ADRs as quickly as possible. And once how long to give the treatment, how much is enough is difficult. It is patient to patient. So that has to be worked up with the specialist at a nodal DR center, higher center. And follow-up has to be done very regularly with clinically, radiologically, and microbiologically. So with this, the last comments I will take
So
from
needless,
ma'am. Yes, ma'am.
yeah, just one carry home message, not to first rule out non-tubercular mycobacteria, to ensure the nutrition of the patient. Possibly that can improve the like the team said, it was due to the disease the weight loss was there. Still, I don't know what was the height of the patient, if 44 was the right weight for her. Nevertheless, my bottom line point was to straight away switch to second line treatment should not be the first reaction. We must rule out what else can help a DSTB patient, provided it's TB and not non-tubercular mycobacteria. Again, I guess we will have to strengthen the lab capacity. In addition to TDM, like Dr. Singla has said, also to look for non-tubercular mycobacteria, because I think in our country it is underreported. Non-tubercular mycobacteria over past cavities or coexisting with TB can also complicate the issue. So one must look at the problem holistically and not just switch to second line drugs which have their own issues. And briefly, sir, bringing in the use of pyridoxine here, I'm sure it was taken care of, which sometimes patients complain they were never given, both with first lines and second lines. So yeah, the bottom line being not just if not responding to these drugs, we switch to second line straight away, but do it scientifically, scientifically sound decision. Thank you.
Thank you so much, ma'am. So now I hand over the mic to Dr. Ashok Bharadwaj, sir, who's chairperson for the NTS, for his vote of thanks.
Thank you, madam. Still, Madam Urushi here. Madam, I must say that many ICMR institutions have got these HPCL. So we can use their services for TDM for purposes. And we had an interesting experience in Dharamshala, Medical College Tanda, Dharamshala. We did a study on TDM in research mode way back in 14-15. So I will share that publication with you. It was an interesting paper. So then, thank you. I must compliment the team from Srinagar, Dr. Naved Nazir Shah. He is an excellent clinician, pulmonologist in north part of the country. So he is very dedicated, and sometimes he don't find time to have his lunch also, because till every patient is seen by him, he will not leave his OPD, and sometimes it is 5-6 o'clock. So thank you, Dr. Naved. So you are doing excellent work as STF chair of Jammu and Kashmir also, and many patients from Ladakh come to him. So then, Neeta Singla madam, for involving National Task Force. So I will, from this forum, though not connected with this forum, I will request all those who have joined, please try to scale up BPAL regimen where it is indicated. So still, as there are enough of the doses in Central TB division, so we must start as many as possible to the patient, so that patients are benefited. So then again, I will say that preventing new infection is my motto. So we have to have TB preventive treatment, and to decline the mortality, we have to have differentiated TB care, for which the medical colleges and the bigger hospitals should reserve some beds for the DSTB patient. So thank you, Dr. Singla, for excellent comments, Dr. Rajendra Prasad. So it's always refreshing to hear Dr. Rupak Singla in north part of the country, and to Dr. Nair in southern part of the country. So I got always new knowledge from both of them. So thank you very much. Thank you all. Thank you.
Thank you so much, sir. Thank you, Team Srinagar, and thank you, Rajendra Prasad sir. Thank you, Urvashi ma'am, always being there to support this activity. Thank you, everyone.
Thank you. Oh, you're welcome. Give me tea.
Thank you, sir. Thank you. Good day.